ये ऑफ कर ले और इधर बैठ जा क्योंकि कुछ भी हो रहा है।
प्रफुल्ल शुरू करें?
Yes, sir, we can start.
Chalo, let's. Good afternoon to all of you, and welcome to this faculty lecture today, which is going to be on a refractive surgery sort of update or overview. And I hope most of you would have joined our recent workshop on phaco refractive. In fact, this would be like a assuring what we have taught you in that particular refractive surgery phaco workshop. So let me take you through the basics presentations and what all things we should be knowing on patients who are coming for refractive surgery. What are the various types of refractive surgery we have nowadays? What type of investigations and history should be taken for these patients? I think that is important for any refractive surgery workup, which would be highlighted today. From my side, no financial disclosure for this particular talk. And you all know every session, every lecture is meant to give some sort of knowledge to people who are listening to a particular talk. So you become wiser. And once you practice, you become more wiser. Therefore, I consider patients who are coming to us are one of the greatest teacher who teach us various things, which may be advantages, disadvantages, positive things, negative things. You learn so many things from patients. So if patients are there, we are there. So we have to respect their sentiments and we have to give due consideration for whatever they're coming to us for a treatment or assurance. So if you talk about refractive surgery, we know that this will correct the refractive error which patient has. That means we can make patient spectacle independence or a contact lens independence by correcting their emmetropia or a refractive error. So normally we are correcting lower order aberration, that is defocus or astigmatism. If you're looking for customized treatment, then you can correct higher order aberrations also. That means if you correct higher order aberration of a patient, the visual quality of these patients will be better. We all know these are safe, very predictable and efficacious, and almost more than 90% cases are within one diopter of intended correction for these patients. And complications are there for any surgery, but vision-threatening complication in today's time is extremely rare. So if you talk about this surgery, it's not like a cataract surgery where we do corrective measures. That means we treat the disease. But in refractive procedure, we treat only the refractive error so that we make patient independent of glasses or spectacles or contact lenses. But you should always remember the pathology behind this remains. If patient was suffering from myopia, so once you do refractive surgery, refractive wise, patient may not have a refractive error in terms of refraction, but pathology still remains. If patient has a high myopia, he or she is going to have a same type of complication, which would be there in a patient with a myopia patient also. Therefore, the subsequent treatment or a follow-up for these patients should be done as per the routine, other types of cases also. So never forget, we are not treating the pathology, we are treating the refractive error only. So how did refractive surgery evolve in last almost now 100 years? So first we had incisional based surgeries, that is radial keratotomy. Then we have a lasers, and subsequently we had keratomes, and now we have a femtosecond laser. So in 1930s, you can see here, it was Sato, from a Japanese surgeon, who started radial keratotomy, that is making incision in the cornea to flatten the central part of the cornea and correct myopia. And his incisions was from the endothelial side. So he should do a multiple incision from the endothelial side in the cornea to correct myopia. And at that time, it was a very successful surgery for a Japanese soldiers fighting in World War I and II. Subsequently, because of various other options came up to correct the refractive error, and this surgery slowly went out of the practice because by the time lasers had come up. You can see here, it was Jose Baraka, who developed microkeratomy in 1963. And he was the pioneer of lamellar procedures. And we all do modern day lamellar procedure because of his invention of microkeratomy. Subsequently, we have a lasers. In 1990, we had a first LASIK procedure performed by Palikares. Subsequently, it was FDA approved. But now we have Femtosecond, which came in around 2001, 2003, approved by FDA, US FDA. And now we have a surgery where we don't make a flap at all. That is a smile, which is approved in 2016 by US FDA. But it's been there for 2008 onwards. So it's there almost now more than a decade. So you can see here, we started with incisional surgery, then we had ablations, then flap-based procedures, and refractive lenticule-based surgeries. So it has evolved in our last 100 years. But if you see, except for incisional surgeries, most other surgeries are still being practiced. That means whatever procedure we are doing to correct refractive error by lasers, they still are commonly practiced all over the world. So this just covered efficacy, visual quality, stability, and safety is there in these cases. This is a meta-analysis of various procedures as I talked about. If you look into here, PRK, EpiLASIK, LASIK, or a SMILE, the results in terms of efficacy, safety were almost equal in all type of surgeries. So we can't say one surgery has led into other surgery going into a background. Procedure-wise, they all are effective. So today, let's meet the requirement of refractive surgery workup. We're going to start with a little introduction of refractive surgery, that is then history taking, examination, and surgical procedure as such. So looking at the introduction wise, you all know, as I talked about, we have various types of refractive procedures now currently being practiced. So firstly, it will be a cornea based. That means incision is out of practice now. Laser based, where we do a PRK or a LASIK, or a SMILE nowadays. For lens based procedures, we are phakic IVL, mainly post-chamber IVLs. Angle supported iris fixated are out of practice now. Then you can do a refractive lens exchange for a very, very high refractive errors for hyperopia and high myopia cases. Or you can combine the two procedures, which is called BIAP. You can do a LASIK as well as the phakic IVLs or other procedures also. Especially those cases where you have anatomical consideration does not provide you to correct effectively the entire refractive error. These are the range of refractive error which can be corrected. These are FDA range. You can see if you're looking for a surface ablation, LASIK, SMILE, they're almost similar. You can correct up to 10 diopter of spherical power. 4 diopters of cylinder can be corrected with these cases. You can see here. So you can correct a large amount of refractive error. If you look into phakic IVLs, then you can go up to minus 20 diopters with ICL. Where you have an Indian lenses, which can give you a much more range also, which can be customized. Let's talk about clinical history. I think this is very important because I know that we have a wide range of resident doctors who are starting, and some of them are senior residents also. But it is important to know the basic things. Is which are those cases which may not be a good candidate for refractive procedure, that is cornea based. A patient suffering for a systemic disorder like diabetes mellitus or pregnant patient may avoid during that period or can undergo surgery after 1 year of pregnancy. any collagen vascular disorder, which is very, very important because entire healing process may be different in these cases. Patient on medications and immune deficiency conditions, and patient who has keloid formation, they may have a very unpredictable healing process, especially after a photorefractive keratectomy or PRK in this case. Age-wise, we all know 18 years plus is recommended. But if your smile is US FDA gives us 21 years as a cutoff. And other important thing is male and female. Sometimes for females, we take little younger age. For males, little older age group as such. Occupational history should be taken because now you have various options where patient may be having an occupation like physical activities, sports. There you can take surgery where you don't have to create a flap like PRK or a LASEK, or you can go for a smile in these cases. But most importantly, patients where you have requirement of a good contrast, then you have to be very, very careful, talk about, because any procedure which we do in the cornea going to decrease the contrast. A person after the LASIK procedure would see 6/5, but if you measure the contrast, that will not be equal to what he had before the surgery with the glasses or contact lenses. So this has to be explained to the patient. This is also important. Refractive stability should be there within 1 year. The change should not be more than 0.5 diopters, spherical equivalent wise. The patient is using contact lens. Soft contact lens should be off for at least 2 weeks. And if your patient is rigid contact lens should be discontinued for at least 4 weeks, so that cornea shape or topography comes to normal. Because contact lens per se will change the corneal topography. And if you take that as a criteria, then your refractive correction will not be predictable in these cases. Any previous ocular surgery should be checked. Past history of strabismus or deviation should also be noted down, because after you correct refractive error, this may change. And poor vision in one eye is also important. We all know dry eye is one of the significant problem after refractive corneal refractive procedures. So a patient already has dry eye, they can have more problems. Therefore, this has to be treated before you jump for a laser refractive procedure for these patients. Glaucoma is no for a refractive procedure, even a suspect cases, because once you do a refractive surgery, the entire corneal biomechanics will change, and detection of high IOP may be a limitation in these cases. We all know herpetic infections, ectatic disorders, these cases are not suitable for a laser refractive procedures. Examination wise, we all know you have to look into all the aspects. We'll go one by one for these patients. And in external examination important, especially look for any lid problems in these cases, treat lid abnormalities. Though these patients are young, but most patients would have contact lens use. They can have blepharitis, and sometimes they can have MGD also. So that should be treated as such. Then you look for an ocular motility assessment, which normally we miss. So that has to be assessed properly, especially looking for a latent phoria and tropia, which may change to change the refractive status after surgery, and breakdown motility status can happen in these patients. So let's see, if you have a hyperopic patient with the exophoria patient coming for refractive procedure, we made emotropia after surgery, there's a loss of accommodation, and patient can develop a full-blown exotropia. So this has to be seen. Let's presume that if patient has myopic exophoric patient, and you have overcorrected this patient, and because once you overcorrection, there's a need for more accommodation for this patient now. Patient will have a full-blown esotropia subsequently. So this is very important. A pre-op high myopia normally would have some IDS. So using concave lenses will help this particular patient, because there will be a base in prism effect, and this will get little correction on IDS. So once you do surgery, the patient can have worsening of IDS and may have a divergent squint subsequently. The patient coming to you, you have to look for their convergence also, and they have to be asked to prepare for or try all those convergence exercises. So the post-op, their convergence can be improved after refractive procedure. Visual acuity assessment, you all know how to do it, and it is very, very important. You have to record uncorrected, best corrected spectacle as well as contact lens vision for these patients. And most often we'll be recovering the same amount of vision after refractive procedures. For a very high refractive error, sometimes there can be a gain in a Snellen's acuity line also. That's because of magnification, minification factor after surgery in these cases. Refraction wise, we should always look for a manifest refraction with these patients. That means you have to do refraction and cycloplegia to get a best achievable visual acuity. If you consider myopic patient, you all know normally we'll take a minimum myopic number or concave lenses to have a best visual acuity for a myopic patient. It's just reverse for a hyperopic patient where we go for a maximum plus power, which gives a best visual acuity. So this way you can correct patients and still have a good outcome. If patient has an irregular astigmatism, that means patient has some sort of either ectasia or early undiagnosed keratoconus, or patient has some sort of surface abnormality, which will be like a poor ocular surface because of tear film abnormalities. So refraction, which is normally done by our optometrists, so sometimes they can be able to diagnose ectatic disorder before we can pick up these patients. Selective examination is mandatory for all patients. Look for all these areas: cornea, conjunctiva, anterior chamber. Anterior chamber especially for cases where you're looking for a lens-based procedures where AC depth is very, very important. Other important area would be look for a white to white, which is important, especially in cases with smile procedure, because you can select the contact lens application size, small, medium, and large, based on a white to white. Ocular surface examination, as I told, is important. You have to do all these tests. Especially now, look for a MGD or a gland assessment should be done. Other important would be doing a BOT, which is important, because once you do BOT, you can pick up so many things apart from the corneal staining or surface staining. You can see the tear breakup time, you can see the tear meniscal size, the quality of tear. All these things will point towards either a normal healthy surface or an abnormal surface. Accordingly, you can manage these patients subsequently. And rule out other causes of poor vision in a patient with high myopia, especially macular pathologies. That may be an important consideration. And these patients, sometimes after surgery, they can have progression of macular pathology, especially myopic CNBM, and patient loses vision. So counseling has to be appropriate for these patients to begin with. The dominance of eyes should also be assessed. That means which right or left eye dominant. This is important for a particular type of refractive correction, where we tend to do a monovision, that is for a presbyopic correction, or a press beyond, where we do a dominant eye for distance correction and non-dominant eye for near correction. So this is important nowadays to assess dominance of eye. As such, it is also important for routine refractive cases also, because patients tend to occlude one eye at a time and see if right eye, left eye vision are equal post-op after refractive procedure, and they will always complain one eye is not doing well as other eye. So once you do a dominance test before, you can always tell them your one eye is dominant, that's why you are seeing better with that eye. So this is also important point for a pre-op counseling for these patients, which will help you in a post-op management of patient where they are unhappy with the outcome, what you have done for correction of refractive error. The most important part of clinical investigation is looking for a cornea or a corneal topography or tomography. If you look into a journey of refractive procedure, as I showed in the beginning, when we started refractive procedure, corneal topography was not a very common instrument. So it is because of refractive surgery now, corneal topography has changed so much and it is being used not only for a refractive surgery, for various corneal procedures as well as for cataract and other procedures also. So it's become a mandatory part nowadays for our investigation of patient undergoing refractive procedure. So let me just briefly take you through, because this is a very, very important part of examination and investigation of refractive procedure. As I said, topography means surface. The surface of a cornea is best analyzed by a Placido system, a Placido disc, or a Placido photokeratoscope. So once you attach a video keratography in this, so you have a more authentic recording of these images. So if you see the older books, you had a Placido disc. Subsequently, we had a Placido keratoscope, and now we have a VKG. But if you're looking for a 3D imaging of cornea, then you require a tomography, and tomography will give you a cut section of cornea from anterior to posterior. Therefore, you can image the entire cornea in a better way. So you know both anterior cornea and posterior cornea, the refractive surface is different, the power is different, and their contribution to a refraction will be different. So therefore, we need to assess all sides, that is 3 dimensions of cornea, for getting a good outcomes. Let's take an example of keratoconus cases. If you have a frank keratoconus, we can all diagnose by all methods. Clinical sign, you can do a Placido, BKG, elevation, any map will pick up keratoconus, because that's very, very evident. Even simple refraction will give you a diagnostic keratoconus. But if you have a suspect cases, in those cases, you don't have clinical sign in keratoconus suspect patient. So that can only be picked up by the topography, Placido, or other ways of doing tomography. But if you have former first state of a keratoconus, that means there is no clinical sign, you cannot pick up with a surface topography also. So that can only be picked by elevation-based maps, which can scan cornea from anterior to posterior. Therefore, tomography is very important tool for giving assessment. So this is the typical picture of a BKG, that is a Placido-based system, which gives you a central axial curvatural map and tells you the entire parameter, which can be a keratometry value, K1, K2, and other areas also, but cannot give you a corneal thickness or a posterior corneal in these cases. So if you want to have a good anterior surface assessment of cornea, Placido-based system are the best. So they can give you a various pattern. This is a spherical pattern. This is an oval pattern. This is a typical bow tie pattern which you see in a routine astigmatism. This is a symmetrical bow tie pattern. This is an asymmetrical bow tie pattern. This is irregular astigmatism. So this case would have some sort of a corneal ectasia disorder. So these are various patterns which you are going to see in terms of axial power map of these cases. But if you look into which are the malignant patterns, that means which may have either suspect of keratoconus or they can point to the keratoconus. So J-shape type of bow tie pattern, or reverse J-shape, inverse J pattern, or a D pattern, they are a highly malignant pattern supposed to be. So if you have a patient with a first degree relative having keratoconus, so these patients will ultimately go to frank keratoconus subsequently. D pattern is also found in a unilateral keratoconus, though we don't consider nowadays unilateral keratoconus. It is a bilateral disease. They're going to have keratoconus subsequently in both the eyes. So if you look into these parameters, so whenever you're taking history of a patient coming for refractive procedure, never forget to ask 2 questions. One is a family history of keratoconus. Second is a family history of high myopia. These 2 things are very important because that will give you a lot of clues for a patient who may not behave properly after you do a refractive procedure in these cases. So this is the off scan, which was based on a slit scanning technology, which also gave a anterior to posterior dimension of cornea. If you see here, this can give you anterior elevation map, can give you a posterior elevation map. So in fact, this is the first instrument to pick up the posterior elevation and gives the axial power map and topography. That means it gives you a pachymetry map also. So this is a typical 4 quad map by off scan. Unfortunately, this particular instrument is no longer being produced by the company now. So these equipments were meant for a normal cornea to begin with. Therefore, their application to a post-LASIK or post-refractive corneas or a cornea which had undergone procedures were not actually predictable in terms of giving a good outcomes. Nowadays, we all use a Pentacam, which gives you a similar 4-quad map. If you see here, this is a anterior digital, you can see a curvature map front. This is a front elevation map. This is a back elevation, posterior elevation map, and this is a pachymetry map. All 4 maps has its importance by picking up various parameters. If you look into axial map, which will give you important parameters, so it can give you a K1, K2, and you can see it also give you a estimating value of 1.3 diopters. It gives you other important things, the graph, your scanning is accurate, all right or not, and it also gives you a Q values for eccentricity in terms of cornea wise. So these are various cutoffs which we consider. Any correctometry value more than 47.2 is a suspect, or a difference between the both eyes more than 2 diopters, K max K2 difference for more than 1.2 diopters, and a skewed radial axis of more than 21 degrees, or inferior superior difference of 1.4 diopters will also be important point in terms of deciding if patient is suitable or not suitable for refractive procedure. Second important part is a pachymetry map, which you can see here, which gives this plus point. You can see is the central part of the thinnest pupil center area, 597. Then you have pachymetry apex, and this is almost matching. Then you have thinnest local area, that is denoted by the circle. You can see a circle here. So this is important. That means thinness of 595, and difference between the pachy center, pupil center pachy apex, and the thinnest point should not be more than 10 microns. You can see the parameters will come here. You can see here superior inferior difference and thickness less than 470 with normal topography, or a thickness around 500 micron less with abnormal topography. So you have 500 micron thickness, but if your topography is abnormal, that cornea is suspect. If you have 500 micron thickness with corneal topography normal, patient can undergo refractive procedure. Other important thing, as I said, is the pachy apex and thinnest location should not be more than 10 micron. This is very, very important point in these cases. Anterior elevation map, you can see here, the parameters would be anything more than 12 micron elevation is suspect. Posterior one, anything more than 17 microns will be a suspect in these cases. With if you look into these cases, immediately you can know what are the various points. This is one more important parameter which is attached to a Pentacam, that is Berlin-Ambrosio enhanced ectasia map, where it gives you the central 3 millimeter area. You can see here is excluded, and then the west field spread is calculated to give you an enhanced picture. So that can give you a better parameters. If you see this particular segment of scan, gives you everything: K1, K2, K max, pachymetry, thinness location, apex, and pachymetry. In fact, if you see this particular chart, anything yellow is suspect. Anything coming red would be a disease cornea. These are various other parameters. If you look into CTSP and if you look at PTI, this should be within the 95 percentile of normal values. Anything more than that or deviation from that will be a suspect cases. But most importantly, the best parameter, if you have to pick up one single parameter in Pentacam Berlin-Ambrosio method, it is D value. So if you have a patient less than 30 years, anything more than 1.6 will be suspicious. But if you have patient which is little older, then up to 2 would be all right for these cases. So apart from values, age is also important factor for a D value also. So I'll just skip this because this is an example of one of the patient. You can see here, it gives you a very nice very nice. You can see a parameter here. It looks like a symmetrical bow tie pattern. But if you look into a posterior area, You can see this is a borderline elevation of a posterior corneal best-fit pairwise. So if you look at Berlin ratio, you can see that it is coming red here and yellow here, and it's looking at D value, which is 3.05. So this is a case of keratoconus suspect. Left eye has a similar picture, and D value is 2.22. So this is a patient, you can say a bilateral early keratoconus. Should not be called former freste because patient does have a significant parameter. So this is a patient which is diagnosed based on a pachymetry value only. So that was the second chart which I showed you. These are normal parameters, less than 5 difference between the thickness between apex and thinness. As I said, it should not be more than 10. Here, if you see here, it is 0.90. So this is definitely a case of keratoconus suspect patient. So this is a patient where you can look into other parameters. If you look here, again here, enhanced map, back elevation much more, and D value is also, you can see, quite significantly higher, 3.18. So this is also a case of a keratoconus suspect patient. So this is a total summary of whatever we covered. So you have anterior sagittal values, you have anterior elevation values and posterior elevation map, and pachymetry. All 4 things should be considered before you label patient for unsuitable for refractive procedure. Pachymetry, just to cover, because nowadays we calculate the residual bed thickness based on patient's corneal thickness. It's not a corneal thickness which is important. It is amount of a refractive correction which you're going to do is also important, because you have to leave a thickness which will be significantly important to resist the intraocular pressure related ectasia happening in these patients. So if you look at residual stromal bed thickness, RSBT should be central corneal thickness minus the flap thickness that is created by the femtosecond or a microkeratome, and amount of depth of ablation. So that should be should not be less than, normally we can take it as 300 micron nowadays, but people go up to 280, 290 microns also. The other important parameter is percentage tissue altered, or a PTA. That is again, you can see a flap thickness plus the ablation depth divided by this central corneal thickness. This should not be more than 40%. It should be less than 40% to be suitable for a refractive procedure. It's important to say here not to go with a single parameter. As I said, you have to look into all the parameters. So you have a pentacam parameter, you have patient refractive error parameter, corneal thickness parameter, then you have a residual bed thickness parameter, and then you have the percentage tissue altered parameters. Combine all these, and then you can say which patient is suitable or unsuitable. This is another important point here, that corneal keratometric values also. It should not be too flat or it should not be too steeper. So if you look into a post-operative keratometry wise, if your procedure is going to give you ultimate keratometry of less than 34 or more than 48, then you should not be doing surgery for these patients also. Pupil size measurement is also very important, because if you have a larger pupil, then you require a larger optic zone, and larger because once you increase the optic zone, the ablation would also be larger in these cases. This is a parameter which is normally used for a patient undergoing a phakic IOL. These are recommendations for a phakic IOL. And the AC depth should be at least 2.8 millimeter more. This we are talking on a posterior chamber phakic IOLs, and should not be more than 4 millimeter also. Though people are using a phakic IOL for a keratoconus patient nowadays also, which is sort of off-label use. White-to-white measurement, which should be within 10.8 to 13 millimeter. Anything beyond that, then the company like Star may not give you a lens, because they don't make lens for these cases. Endothelial cell count should be normal. Normally at this stage, it should not be an important criteria. Again, we said the post-op keratometry and patient has a too flat or too steeper cornea. Here also, they could have a more higher order aberration and may not really have a good outcome in these cases. So this is how we normally go. So if you have a patient who has come for a refractive procedure, Residual stromal bed thickness you have calculated, which is more than 280 microns. PTA less than 40%. Post-op K within 34 to 48 diopters. Then you can do a corneal based procedure. So that means you can do any refractive procedure, laser procedure with this patient. So if you have a RVT less than 280 microns, PTA more than 40 and the keratometry is beyond 34 and 48, then you have to think of a lens-based procedure. But the important thing here is you should have AC depth, which is more than 2.8. But today, if you look into today's perspective or refractive procedure, the patient, it's not that patient who are unsuitable for a laser procedure are only be taken for a phakic IOS. Phakic IOS is coming as one of the primary modality of treatment in many cases also. Earlier, it was only for a higher refractive errors, which were not suitable for laser-based procedures. Nowadays, people are doing for a moderate degree of refractive error also, because it is sort of a reversal procedure, because you can remove the phakic IOS if it is not doing appropriate way in terms of not suited in terms of thickness wise. Sometimes the bulk may be less or very high, may cause glaucoma or may cause lens opacity. You can remove them and replace with a new design also, new sizing. So in that way, these procedures also are a primary procedure nowadays. Consent, as I talked in the beginning, is very, very important for refractive procedure. Any procedure where you're going to alter a part of a body, let it be eye, let it be cornea, or let it be cataract surgery, or any surgery in the body where you remove something, the consent has to be perfectly noted down. Physical written consent should be there for all these patients. And explaining all the pros and cons of refractive procedure is very important for these patients. Let me take you to the ablative procedures. What type of ablation we do for these patients. I think by this time I've covered the history taking and the important examination investigative points. Is there any question from people, Dr. Agam? that is also I can't tell you just exactly. I have to see that slide again. But the important thing is it is how we calculate the amount of ablation going to happen in terms of per diopter wise. So each diopter will have a particular amount of a tissue to be ablated from the cornea. So it will depend on various parameters. If you want, I can go back to that slide. You have this, this formula tells you amount of refractive error into optical zone square divided by 3. So this shows that you have refractive. Suppose we have a refractive of 4, and if you keep optic zone of 5, so you have a different amount of tissue taken away. With the same refractive error, if you keep an optic zone of 6, so you're going to have a different amount of tissue corrected. Tissue will be ablated. So optic zone is also very important consideration. So sometimes to save the tissue, sometimes you go for a small optic zone. But once you go a smaller optic zone, you're going to create the transition zone, which is going to come to the pupillary margin, and patient can have halos and glare. So it's always better to have a optic zone which is larger than the mesopic pupil size. So optic zone is a very important consideration for a amount of tissue which is going to be ablated for these patients. Okay. Any other question? Okay. Let me take you to various laser profiles which are being used for correcting a refractive error with these lasers. So you can have normal pattern, which is normally we call wavefront optimized or aspheric treatment, which takes care of spherical aberration induced by the laser pattern which we are doing in the cornea. As cornea is not absolutely spherical, therefore the laser spot which are going to apply to the cornea, center to periphery, going to have a different amount of energy being delivered. So that's going to induce spherical aberration more often. Therefore, you have to have a ablation in such a way that gives you a spheric way, so that it corrects the spherical aberration. Then you have a wavefront guided, or you have a contoura, which is a new way of thinking these patients. So if you have a lower order aberration, defocus, then conventional LASIK would not be absolutely suitable in these cases, because patient does have a wavefront abnormalities. There you have to look for correcting these cases in different way. Higher order aberrations, as I talked about spherical aberration, you have to aspheric design, or coma, then you go for a wavefront type of treatment. So normally if you do a routine conventional LASIK, which we had earlier in 90s, so most patients, though refractive will be corrected, but the quality of vision was never good in these patients, which now has improved by looking into correcting their aberrations. So you can measure their aberrations beforehand. If you have a higher order aberration less than 0.4 microns, then aspheric or optimized treatment can be done. If you have a higher order aberration more than 0.4 microns, then wavefront guided LASIK can be done in these patients. So this is a simple chart which explains, this is a very old slide of mine, 90s slide, but it still holds true. So this is, you can see a patient who had a pre-existing higher order aberration. And this is a induction of aberration in these cases. So any procedure which is going to compensate the induced aberration, as I said, once you put a laser in the cornea, in a cornea which is not spherical totally, you're going to induce aberrations. So laser ablation should be such, we should take care of induced aberration, as well as if patient has pre-existing higher order aberration, that should also be corrected. So if you see here, we earlier used to have standard LASIK or a tissue saving LASIK. They are no longer used now because they could not correct either of these. But if you look into a treatment like personalized wavefront guided, that means it's going to correct only the pre-existing higher order aberration. Doesn't take care of induced aberration which normally happens, that is a spherical error. So wavefront guided does take care of a pre-existing one. Best would be a treatment which combines both of these. That means which can take care of induced aberration during the laser procedure or a flap making, or patient who already has a pre-existing higher order aberration. That is called personalized aspheric, which can be wavefront guided also, or which can be a contoura type of system which looks into the anterior aberration and the refractive error correction for these patients. Custom LASIK is basically, again, we have to take a entire topography based assessment of these patients, and the picture should be absolutely reproducible. You have to have multiple images to calculate the aberration profile of patient, then treat these cases. That is how a contour is based on. So this is a system topologizer which scans the cornea. It's like a pentacam. Takes multiple images. Then you have to select at least 4 images which are almost similar. With these images and refractive error which patient has, the system will calculate the new pattern of a laser ablation, and this will correct the, apart from the refractive error, the surface-based aberrations supposed to give a very high quality vision in these cases. The first procedure which I want to talk about is a photorefractive keratectomy, that is a PRK, a very common procedure till date in these cases because you are not making flap. Therefore, flap-related complications are not there in these cases. The only thing which is to be done in these cases is to remove the epithelium effectively. So that can be done by alcohol. Normally, we use 20% alcohol for 20 seconds, which gives a nice epithelial basement membrane detachment. You can remove very easily subsequently. Or you can use a mechanical method, spatula, blades, or rotatory brush, by which you can remove the epithelium. Or you can use Excimer laser directly, which is very commonly practiced nowadays, especially a wave light laser. So that is called transepithelial PRK or streamline. Or you can have a LASIK also, which is like a PRK type of procedure. So these are advantages of PRK. As I said, no risk of corneal flap. The only problem in these patients is the recovery is slow. In a PRK patient, they have a much more painful period subsequently, and there's always a risk of haze coming up subsequently in these patients. So if you see here a small video, this is a very old one which I had used earlier, which normally we put a little trephination so that we have a good contact with the epithelium. Put alcohol for 20 seconds in a well. You can see alcohol being put for 20 seconds. Take it off, wash, and subsequently you can remove the entire flap. So this was the LASIK when it came. We had to preserve the epithelium also, and this was after we complete the Excimer laser. This flap was replaced onto the cornea. Later we realized it is not important to replace the flap because it's not going to improve the outcome as such. So nowadays we remove the flap very rapidly and subsequently do a laser in this case. So after laser, the irrigation is done. So PRK as such, as I said, if you heard me correctly, one of the major problem is the post-op haze in these patients. So how do we control the post-op haze in these cases of PRK, which can also be an important factor for a regression happening after PRK in these cases? The normal formula people use mitomycin C, which is very commonly used. The formula which I personally use is for less than 3 diopter correction. I use mitomycin C for at least 14 seconds. 3 to 6 diopters, it is for 27 seconds. Anything more than 6 diopter, it is for 54 seconds. So some people do a 10 second per diopter correction. The mitomycin C has changed the entire concept of correcting the haze or avoiding haze in PRK patients. Even after you develop haze after PRK, you can use mitomycin C to correct these haze. The second important procedure is laser-assisted in situ keratomeliosis, that is LASIK. You can see which is a till date most commonly performed surgery in for a refractive error as such worldwide. So there will be 2 ways you can make the flap. So why did people think of making flap? Because, as I said, the haze production after PRK, because you are hitting the Bowman's membrane in these cases of PRK. To avoid that, Palikaris came up with the idea of LASIK and used mechanical microkeratome, which earlier developed by Baraka. To use a blade here, Femtosecond is basically by laser to make a flap. After you make a flap, then you can ablate with the Excimer laser. So this is, if you see a picture, first we use a suction ring to have the eye fixed as well as making the cornea flatter. So this suction ring can come in 2 sizes, Asian and larger size. And then the keratome runs over this cornea. This is a track which is there to run a microkeratome. So it makes a flap. After that, you ablate and you can deposit it back. This is a femto laser. So first, after you have an ablation of a cornea, makes a canal first, then subsequently makes a flap. The flap can be lifted and you can ablate like you did for a microkeratome also. The femtosecond laser is photo disruption. Thermal interaction of laser is basically like you do for a photocoagulation. Photo ablation for Excimer laser. So basically it is the spot size and the distance between 2 spots which is the important consideration for a femtosecond laser to create the separation of tissue without causing damage to the surrounding structures. So this is a high energy photo disruption which is happening. It forms a plasma or creates a bubble. The once these 2 plasma bubbles coalesce, they form a larger one to separate the tissue like this. So nowadays we are looking for a smaller spot size so that you have a lesser spot separation, low energy and high repeatability. Therefore, the thermal damage doesn't occur to the area. Recovery is faster, and the tissue or created, the cut created is also much smoother. These are various femtosecond laser platforms available. Beautifully done by Dr. Manpreet Kaur. This slide. It's very difficult to have these type of tables prepared. So commonly you can see Intralase is there, which is 150 kilohertz machine. But if you see Visumax, we use 500 kilohertz system, Wavelight 200 kilohertz system. But it is one of the highest frequency laser is Femto LDV or GMR. That is a 5 megahertz system. So that gives you a very high frequency, low energy, pulse energy. Therefore, you can create the sub 90 micron flaps also with this laser. So once you talk about femtosecond laser flap making, there are three important aspects for that. The first, as I showed, canal formation or canal creation. There has to be a specific parameter for that, because if canal is not prepared well, you're going to have an OBL formation. That is oblique bubble layer formation. If it comes to pupillary area, then your results are going to be different. Then you have flap-based parameters. That is the size of a flap, the spot size, line separation, flap thickness, flap diameter has to be assessed accurately. As we discussed, it will depend on the type of refractive you are created. That means if you have a higher cylindrical values or the pupil size, major pupil size, accordingly you can change the ablation profile. For that, you have to have a flap diameter suiting to that ablation profile. Side cut is important because that is going to have a particular angle so that your flap attachment is better after you create the flap in these cases. This is how femtosecond laser evolved in the last 20 years. It started at 6 kilohertz, now it is almost 5 megahertz system are there. To higher the energy, you require lesser spots size, less energy, a high repeatability in these cases. So just to compare microelectron versus femtosecond laser, you can see predictability wise, femtosecond flaps are within 4 to 5 microns of predictable your thickness. Suppose I take 110, it will be within 4 microns of 110. So see here, these are the best keratomes we had. These are best keratomes we had. Let's take Hansetome we had. If you think of 160 thickness, so it can range from 87 to 171. See the huge difference. You're looking at 130 microns. See the difference, 146 to 250. So this is very, very unpredictable in these cases. And flap is also meniscus size, the keratome, and planar in femtosecond laser. So it will induce lesser hydroabrasion. So this is a typical femtosecond flap, beautiful flat flap creation. Well, it is little irregular meniscus, thicker in the periphery, thinner in the periphery, then it becomes thicker, then it little uniform in the center. So that's going to induce spherical aberration or a higher aberration in these. What I was talking about, if you have unpredictable thickness creation, your calculation of PTA is going to make a huge difference, especially in a cornea which is borderline. Suppose you had only 500 cornea and you calculated as per 100 micron flap thickness, and that gives you 290 RSPT. But if you cut 120 or 130, the RSPT becomes 250 or 260, which is not acceptable. Therefore, predictability of flap making is very, very important. Smoothness is also almost same with the femtosecond laser as well as the microkeratome. People talked about more inflammation of femtosecond laser, but with newer devices, newer generation system, the inflammation is not there at all. So these are various studies proving this is a mitochondria being assessed with cell death apoptosis by tunnel assay, Hansetome, keratome, and this is a Intralase 30. Now we have Intralase 150. The amount of apoptosis is almost similar now. And if you look into a confocal microscopy, there's no difference in terms of keratocytic activity. This is one important point which we do ask to our students. What would be the intraocular pressure generated during the flap making? If you look at femtosecond machines, the IOP can go up to very, very high, 180. And this is a 200 kilohertz system which we use, goes up to 80 and up to 100 millimeter mercury. Macular keratome, it is much higher than that also. So macular keratome is a single pressure, because one pressure will, and this is beyond the limbus area. While femtosecond, you have a two pressure rise, one during the holding the contact lens onto the ocular surface, then subsequently ablation. That is the time where pressure goes almost up to 180 microns. But that time is only for us very less than 30 or 40 seconds. Outcome-wise, both femtosecond and macular keratome is equally efficacious, not much a difference. But quality of vision, as I said, is much better with the femtosecond flap because it is planar and less induction of higher order aberrations. Complication, because it's definitely less with the femtosecond flaps, which is much more in the macular keratome induced flap. This is a typical complication with the femtosecond laser. The intracameral bubbles, because sometimes bubbles can seep in through the angle area into the antechamber. So this will not allow laser ablation to happen with the tracking system. OBL, this can sometimes, if it comes to the pupillary axis, then it can cause unpredictable outcome in these cases. Sometimes you can have a vertical breakthrough of a laser application. You can see here normal flap making, but in the area where we are making the tunnel, the entire flap break away. So you don't have to lift here, wait for 2 to 3 months, and you can redo the entire procedure. This is also a very important complication both after macular keratome and femtosecond laser. This is called diffuse lamellar keratitis, which is very less seen nowadays. It was very common earlier because of various reasons. If it's within a grade 1, grade 2, you don't have to do anything. With a steroid, it will be all right. But it becomes grade 4, then you have to lift the flap, irrigate, and then start frequent steroids. Initially, it was thought about because of a powder from the gloves or the instrument which you use can create these inflammations. And what about the actual laser which is ablation? That is argon fluoride Excimer laser and 193 nanometers, which is being used effectively. We see here, we started with the broad beam technologies, and these are very difficult, especially for astigmatic treatment. Subsequently, we had a flying spot treatments, which better controlled ablations, less induction of higher order aberration in these cases. And we could do a hyperopic treatment also. And that was possible because we had a built-in tracking system, which the entire laser spots were tracked by the tracking system. No laser spot will be coming one over other. And if the eye movement is too much, which tracker cannot assess, then laser will stop. Then we had a customized treatment coming up with the 5th generation systems. Now we have a 6th generation where we have very faster ablation rate. Tracking devices also become very, very effective. We're looking for a cyclotorsion also. So if you look here, we are looking for high frequency lasers, 400 to 1000 hertz systems. And the treatment time is very, very less in these cases, and advanced fluence, which is happening in these cases. Just to give a little idea, if you look into a wave light machine, which we use in RP center, the treatment time is less than 1.4 seconds per for a 6-millimeter optic zone cases per diopter. So this is a very, very effective treatment. Earlier, when we started, it should take almost a minute for a completing procedure. Higher order aberration is less because of the spot size for these cases are very, very less. If you see a spot size here, they're almost less than 1 millimeter spot size. And they all are flying spots. That means each spot will not come to the same area immediately. It might come after a few spots. These are various treatment profile available with various systems. Wavefront optimized, as we discussed, going to correct the induced aberration which is going to happen by flap creation and by doing ablations. Then you can have press biopic correction also available with few systems. Like we have MEL 90 with us, which gives you a press bound treatment. which is effective for many people who are presbyopic now. In future, one of the largest segment of people are going to presbyopic for corrections. Then you have a wavefront topo-guided treatment, which is available with us also, custom Q and topo-guided treatment, which is nowadays currently being practiced by many people. So as I said, the newer generation system has a very high-speed tracker, which looks into a horizontal, vertical, as well as cyclotorsional assessment for hitting the cornea with the E-spot. That's how you're going to have more predictable systems. If you have a tracking system which is more than 1000 hertz, so you can have almost zero latency or less than 2 millisecond latency for detecting the ablation or eye movement. Comparing devices, as I said, for a laser ablation, you have various systems which are currently available. We have Bell 90 and Wavelight with us. Then other systems like Swan, Nidec, they all are good systems. If you compare them, they are all within the guidelines or FDA requirement as such. Complications can be divided, you all know, can be intraoperative, early postoperative, or late postoperative as such. So these all you can see in the books also. Let me take you a few important things. Corneal haze, I discussed, this is normally seen in a PRK patient. Nowadays, apart from doing a PRK for routine primary cases, PRK is another good option for a retreatment. Retreatment after a failed procedures, especially like a SMILE patient, PRK is one of the preferred way to retreat. And they have a different response. A primary cornea and a secondary cornea have a different response to PRK. Therefore, mitomycin C application also is different in these cases. If I'm using mitomycin C for a secondary procedure like a haze after PRK, or I'm doing PRK for a post-SMILE patients, so my duration of mitomycin C will be much longer. Keratome complications, basically buttonhole irregular flaps is normally seen in those cases where keratometry is either too flat or too steeper. Thin flaps again happen when your suction loses or suction is low. And sometimes if you have a very steep cornea, you can have thin flaps, irregular flaps. Free cap also is common with microkeratome, especially the very flat cornea. Around 40 or less cornea can have chance of free cap. Normally, to avoid this, you need to know proper assessment of cornea. These cases will have a high risk, therefore these patients may be better suited for a femtosecond laser flap making. Perforation is very rare. I have not seen personally any perforation happening with the keratome or a femtosecond flap making. This is a very common picture and commonly seen after both femtosecond and microkeratome flap making. Normally seen within the first few days. If this type of wrinkling is there, that is called flap stria, has to be immediately taken care of. Normally they'll start from the hinge area because this is an attached area and they go across to us, and sometimes there can be a dislodgement of flap also. If it is severe, causing visual acuity hampering, then you have to take the patient to the OR and relift it and reflatten by ironing the entire flap. If it is more than 1 day old, then you have to remove the entire epithelium, because epithelium will go into these grooves. So unless you remove the epithelium, the flap cannot be ironed out. Infection after a LASIK procedure has been reported widely, but the incidence is very less than 1.5%, 0 to 1.5%. Does happen within the first week of a surgery. Normally seen with the microkeratomes after femtosecond laser is very rare, and a SMILE has not been reported. I think one case has been reported till date, but this normally happens with the atypical mycobacterium, and they are classically known for a post-LASIK infections, and these are interface infections and very difficult to manage. So sometimes you may have to sacrifice these flaps to get accurate microbiological report and treat these patients. Little bit of a SMILE, that is a non-flap based surgery, or we just create the lenticule intrastomal and remove subsequently. And the indications is similar to LASIK patients. apart from it's not yet been approved for hyperopic corrections, which will come very, very soon because the trials are going on. Just to show a small video of a smile surgery, it is a normally pupil-centered treatment. So this you can see we are making the lenticule. So from this periphery to center, so they will have a side cut. Now we'll make a cap, which will come to center to periphery. So this is a creation of a cap being happening. Then you will have a side cut, which is normally 2 millimeter, is the smallest one. You can see this is the lenticule, refracted lenticule. This is the cap, side cut. You can see we'll open the incision now with the hooked instrument. The 2 rings are very clearly visible. So first, normally we do an anterior dissection so that we can separate the make a pocket anterior to the refractive lenticule. You can see the ring is clearly visible. Now we'll go posterior to the refractive lenticule to create the pocket there. And this refractive lenticule will be extracted after making the separation of lenticule from anterior and posterior side. So this is a spatula by which you will make the anterior separation. So you have to make sure that you don't damage or enlarge the side cut here. Gentle movement of anterior separation. You can see, and you would have seen this in live surgery also. So we have completed the anterior separation. Now we'll go behind and then take out the entire area. First we remove the 6 o'clock, then 9 o'clock, then 3 o'clock, and subsequently you can take out this lenticule. The amount of tissue which has been removed with smile and with LASIK is almost similar, because each diopter correction, the tissue ablation or tissue removal is almost similar in both the cases. The advantage here is we are retaining the flap, and subsequently the outcomes will be better. This is immediate post-op in these cases. You see this is after 1 week, and this is the OCT. You can see this is the area from where we have taken out the lenticule. This is after 1 week of surgery. Safety is almost similar to LASIK patients. If you see here, the area from where we are taking lenticule and area which is ablated in LASIK is almost similar. But despite that, the biomechanical strength of smile patients are better, because we are cutting only this part. The entire area is retained. When LASIK, you are cutting the entire 270 degree or 280 degrees, and you're cutting all the nerve plexus. Here only the superior few plexes are cut, therefore the dry eye is going to be less. The tissue is going to be maintained better, and mechanical stand will be much better with the smile patients. So this is one of our patients. You can see smile patient pre-op. This is a 1 month and 6 months. It is as normal as pre-op cases. LASIK at 6 months also, it is still not recovered. So that's a difference which is going to happen with these cases. Faking IOLs range is there. You can correct up to -3 to -23 diopters. Large amount of cylinders. Few important things has to remember faking IOLs. AC depth more than 2.8, less than 4 millimeter. Wide to wide between 10.8 to 13. Good interstellar count. Rule out lenticular opacity. This is the AC depth wise, because it's not only the wide to wide which is going to determine the size of ICL. It is the AC depth also. Just see here. If you have a wide to wide ACD here, if you let's take wide to wide 10.5 to 10.6, ACD less than 3.5, your size is size is 12.1. But if you have an ACD much more, the size is going to change. So whenever you're working up the faking IOLs, clearly check for a good AC depth, that is from endothelial side to lens anterior lens surface. For a larger pupil, you can have a larger size ICL or faking IOLs. Nowadays, you can see what is happening to your lens after implantation also. You can see the bolt on the table with IOCT, which is attached to your microscopes. Any shallow or a steep bolt can be picked up very easily in this case. Refractive lens exchange is normally for those patients who are around 40 plus, and they have a little bit of lenticular changes also. And we can give a nice presbyopic lenses also. But cases which are hyperopic, sometimes more than +6, +8, and in AC depth is also less to accommodate phakic IOLs and not suited for lasers can also be considered for refractive lens exchange in these cases. Presbyopia, we do have lasers, but majority of them will be happy if they are beyond 50 years for a IOL-based surgeries. But nowadays we are looking for a monovision options with presbyon, laser ablation of cornea, making laser multifocal corneas. Like presbyon, people use various other devices intrastromally, that is inlays been tried. This is one such inlays, Kamara's inlays, which is not being used now. There were almost more than 20,000 implants being done, and these implants give a good outcome as such. People are using now a smile tissue as inlays to correct presbyopia. I'm not sure how effective that's going to be for down the year, because the tissue is going to regress inside the stromal bed. Challenges are still there for all exam laser based procedures, especially hyperopic corrections are still a challenge. Smile, it has to be approved yet. As I said, presbyopia, major challenge, because a large group of people, segment of our community will have presbyopia. If you have a good surgical options, then we should offer this to these patients. Just now, whatever options we have, let it be laser based or lens based, they're all compromised. Any decentration of ablation can create a huge optical problem for our patients. So decentration needs to be avoided of all laser procedure. Even for a phakic IOL also, decentration will cause glare, halos, and peripheral, you can say, vision problems. Customized ablation still has to be perfected. In future, all this can be combined if you have some sort of artificial intelligence for a pre-op investigations to pick up poor patients for a refractive procedure, or pick up undetected ectasia in these patients. Similarly, for ablation also, artificial intelligence will come, which will going to give you a more personalized treatment for each patient. This is a summary of femtosecond flap making, especially cases where we know that people talked about inflammatory response, which is not there now. They do have a better visual quality than a microchrome flaps. So people should shift to a femtosecond. In fact, world over, people have all shifted to femtosecond laser flap making. It is a disposable system for each patient. Therefore, the cluster infection, which is seen in microchrome, will not be seen with the femtosecond lasers. As far as laser ablation is concerned, few important things you should know. We all have a smaller spot size lasers, examer lasers, faster repetition rate. These two combined will give you a lesser energy delivery to one part of the cornea. Therefore, the effect of a laser will be better, and inflammation will also be less. High-speed tracking system, because tracker is the one which has improved the outcome for these spot-based lasers. Earlier, we didn't have a tracker, therefore we had a broad beam lasers. Pupil size monitoring is also very important. Minimal induction of aberrations, which is happening after a customized laser which you are doing, and online pachymetry, which is not very important significant thing, but if it is available, you would know how much your ablation has taken away the tissue from each cases. So we have latest generation exam laser systems. We have latest generation femtosecond devices in our refractive, you can say, stations in RP center. People should have access to these. You should all go with the rotation, assist your surgeries with your SRs and faculty, so that everybody has access to these areas. To summarize, as I said, it's a more predictable, most satisfactory ophthalmic procedure after cataract surgery, as far as patients are concerned and surgeons are concerned. Femtosecond laser, major shift in the recent years, especially smile, and major challenge due to presbyopia. Towards the end, just one question to all of you. Is it only a cosmetic surgery? Because you people have a habit of writing in OPD cards, patient has come for a cosmetic surgery. So sometimes that can be a big issue in a legal fight. So I say it is also a therapeutic surgery. It's not going to correct the disease per se, but it's going to correct the refractive error, especially in cases with a high refractive error, because without glasses they are blind. So this is going to improve their blindness category. Second, the psychosocial attachment which is there with these patients is going to be treated by this therapeutic surgery. So it is actually a therapeutic procedure for these patients who are actually having these regressive psychologists sometimes. And sometimes they are really handicapped, like people who have sports as their career. So spectacles will cause problems. Contact lenses are not suited for sports people nowadays. So these surgeries would definitely improve their quality of their life also, especially people who are in golf. They have undergone, you can say, customized LASIK procedures, and their vision has improved. So it is actually a therapeutic procedure. I would again thank you for you people who are listening to me, though I have little 15 minutes more than slot I had taken. If there are any questions, I'll be happy to answer you all.
Thank you, sir. I think that was a very comprehensive overview of refractive surgery and covered everything. I think there should be no questions after this.
Sir, can we do one eye LASIK? Sorry, I couldn't read that. Where do I read this? कहाँ पर आएगा ये?
Sir, in the chat box, right
Hello?
side, top up. On your right side.
Hello? Agam? Kapil, can you hear me?
Yes, sir. Yes, sir.
How much suction pressure is applied while talking in a LASIK? I think the first question was, can we do a one eye LASIK, one eye ICL? I think I could read that question accurately. This can be done. Sometimes one eye has a higher refractive error and high cylinder also. That eye can be taken up for a LASIK, for a phakic IOL. But other eye, if you have a very less refractive error, then you can think of LASIK. If patient has more than 3 diopter refractive error, I would go both eye phakic IOLs, because the visual outcomes will be totally different. The refractive outcome may be similar, but the quality of vision with ICL is much better than what would be with the LASIK procedure. Second question I just flashed was how much is the suction pressure during LASIK flap making. As I said, if you're using a microkeratome system, the suction pressure can be going up to 130 to almost 190 millimeter mercury. And the time taken for a flap making with the microkeratome is much longer than a femtosecond. Hello?
Yes, sir. Yes, sir.
The time taken is much more than femtosecond laser. As I said, in the femtosecond flap making, there is a section 1, section 2. Section 1, the pressure can go up to 40 to 50 millimeter mercury. That holds the entire eye in a position for an appellation to occur. Once you have an appellation, the suction pressure goes up to 130 to 150 millimeter mercury. But at this juncture, the entire procedure doesn't take more than 10-15 seconds. So whatever pressure you have, it is there for lesser time with the femtosecond device. Yeah, very good question. Normally, people take 50 microns as a rough guideline, but you are right. We should be doing epithelial mapping in these cases with RTPO ASOT, then plan accordingly, and that would give you a good way to assess these patients. But unfortunately, even after that, also there can be a little bit of plus minus, because When we take the epithelial mapping, patient is without anesthesia and patient in a sitting position. Once you take the patient in the OR, patient would have already received a few drops of a paracaine. The epithelium would have swollen a little bit. So there will be some disparity, but that will give you a good rough guideline. Normally, if you see all normal patients, the epithelium is around 50 micron only, plus minus 2-3 microns. I think, as I said, to clarify the issue, the indications, contraindications, refractive outcome is almost similar with the LASIK and a SMILE. So there's not much a difference. The difference which is in favor of SMILE is first, it is we are not making the flap. Therefore, flap-related complications are not there. But apart from that, if you look into a retreatment where you have done a flap-based surgery like LASIK is much more simpler. And we have known that for decades, more than 2-3 decades. And we know how to retreat also. So that would be a little difficult option for a SMILE patients. Second important aspect is dry eyes. Because all these patients who are undergoing refractive procedure, in India, I think if you look into our patients, we have not done an accurate analysis. Almost around 40% of our cases do have a contact lens use history. While in the West or other Asian countries, it will be much more. And these patients do have some sort of a pre-existing dry eyes. There, I think overscores on a LASIK patient because the dry eye initiation is also less. If they have a dry eye also, the recovery is faster. Third important thing for a SMILE patient is, apart from the professional reasons, what we have seen, the outcome of refractive correction keep improving up to 1 year or 2 years. They don't regress. In fact, they improve subsequently also. So that is a good factor in these patients. And it doesn't have the larger transition zone which happens in LASIK flap making or laser ablation which happens with the Excimer laser, because SMILE is a single femtosecond surgery. So once you don't have the peripheral transition zone, the peripheral, you can say the visual outcome, halos and glare is also less. Other important thing which may not be very important, but cases where you have a cornea which is towards a flatter side or towards a steeper side, after a lenticle-based extraction and Excimer laser, the corneal topography or a keratometry change is less for dioptric correction of refractive error in a SMILE patients. So that's also an important area.
So what is the highest correction in terms of astigmatism that you've done with SMILE or our machine allows?
I think we do have a little bit of hesitation because we have both the devices with us, Excimer laser and SMILE. If I would have had only SMILE, then would have gone up to 3 diopter cylinder. I think that recently FDA has approved up to 3 or 3 diopter cylinder also. But I have gone up to 2 diopter cylinder with SMILE also. Though I'm not sure how effective the concept of putting a mark on the cornea to take care of a cyclotorsion which happens with the lying position, which may be okay for a high cylinder error, but if you have within 1 diopter cylinder, it doesn't really make a difference. But we know that the future systems are going to come with the tracking system in SMILE also, which will compensate the cyclotorsion which may happen in these cases. Yes, you had some other question, Agam? That's a very dubious question, because no refractive procedure should be given an option to such if they have a glaucoma suspect diagnosis kept with them, especially patient who has a family history of glaucoma or a diabetes associated. Because whichever surgery we do, smile or a LASIK or PRK, your post-op IOP measurement going to be much difficult in these cases. I'm not sure the you can say the people use Corbis for taking intraocular pressure for these patients pre and post, because for every patient Corbis may not be available to check the intraocular pressure, and I'm pretty sure most patients will not go for refractive procedure. And phakic IOLs again should not be recommended for these patients with glaucoma suspect. If we have to go for one procedure, I might go for a smile for these patients, because you still have a biomechanically important surface than a flap which doesn't support the biomechanical strength of a cornea. The smile may be little better in these cases. And as such, the pressure build up during your procedure is very less with the smile, as compared to the femtosecond where you have 150 as a millimeter mercury pressure generator. In a smile, it doesn't go beyond 35 millimeter mercury.
I think there are no questions. There are no questions, then we can conclude the class, sir.
Yeah, okay, good.
Thank you so much, sir. Thank you for a very exhaustive. I think if somebody listens to this lecture, then they don't have to read the refractive surgery from anywhere. Yeah, because it covers everything, and not only for the postgraduates, but also for the fellows, because it covered even the advanced aspects of
Yeah.
refractive surgery, sir.
Okay, thank you very
Thank
much.
you so much.
Actually, people have logged in. That's great. Despite the work has increased, people may be stuck in the OR sometimes, and the post-op and the admissions have also increased now. I just saw a mail from Dr. Ramesh saying that OPD is so crowded. What to do? We have to work. Thank you again. Wish you all the best. Thank you.
Thank you, sir.
Okay.